comes to ACL special tests, you got to make sure you're doing it correctly, right? Because the whole purpose of it is to check for instability. That's what you're checking for, right? Instability. And it's a measurable point where you're trying to find that firm endpoint or you're trying to find the degrees of laxity, correct? So again, I think this picture does a pretty decent job of illustrating when you're looking at this picture here, it's not up, right? It's forward or anterior. So when you put the knee at 30 degrees, you got to make sure that you're translating or attempting to translate the tibia anteriorly in that 30-degree plane. Does that make sense? Because you do put the knee at 20 to 30 degrees, correct? What's the answer?
Yes. Oh,
The answer is always yes. Right? He is kind of living proof of that. This is a weird class. All right, so again, and then when you move to the anterior drawer, you put the knee at 90 degrees, correct? So when you're translating anterior, you got to make sure you're anterior. But again, the answer isn't always up, correct? It's not up, it's anterior, okay, or forward, if you will, okay? So think about that when we go into lab coming up here shortly, because I want you guys to practice doing it correctly for an hour, hour and a half, right? So you get some value out of it. That way when you get to phase 2, you're not lost in the sauce, okay? You will be anyways, but not, hopefully not with the ACL test, okay? There's a lot coming at you, okay? So which one is the most sensitive though? Is it the drawer test or is it the Lockman's test? Lockman's. So it's super important to get a Lockman's test, okay? Anterior drawer, sure. If you have a positive anterior drawer and a positive Lockman, tells you something. But definitely got to get that Lockman's, okay? Pivot shift test, again, everybody tells me, right? Oh yeah, I did a pivot shift, it's positive. I'm like, no you didn't, right? By default is to not believe the student because I'm like, pivot shift tests are hard even for trained and seasoned providers, okay? No questions about that? All right, moving on, diagnostics. When we're talking about ACL tears, you're like, it's soft tissue. Why would we get x-rays? You're going to get x-rays to check for bony osseous abnormalities and to look for malalignment, correct? So whenever you're documenting your x-ray findings, it's not negative, right? It's not unremarkable. That's what a radiologist says, okay? When they're not trying to get paid by the word. But you're looking for no acute osseous abnormalities or malalignment, okay? Make sense? Excuse me, because we're going to talk about PCL tears, and maybe you'll see the tibia translated posteriorly, right? So that's what you're looking for. So what is the diagnostic finding that is pathognomonic for an ACL tear? The Sagon fracture, okay? You have to know that. That is low-hanging fruit when it comes to pants, okay? Sagon fracture is a lighthouse that tells you that the patient has an ACL tear until otherwise proven, okay? So it's an avulsion of the lateral tibial eminence, or lateral capsular margin. Is it a tibial plateau fracture? No. Okay, so don't get those two confused. That's why when we went through our anatomy review, we talked about what a tibial plateau is, and now you understand that this is the lateral tibial eminence or the lateral capsular margin. So, having said that, what does your ACL prevent? Anterior translation and rotary stability as well, but secondary for the rotary, correct? So that's how this happens. It's that plant pivot pop, okay? Pulls that little bit of the capsule off, pulls that little bit of the lateral tibial eminence, and it shows up like this on radiograph, okay? So if you see this again, you're highly suspicious for an ACL tear, and remember, you may not be able to get the best exam initially because of the swelling, correct? The answer is yes. And so you want to make sure you continue to surveil the patient, have them come back in 2 weeks, send them to physical therapy, because you saw this on x-ray. Have I beat that cow to death yet? All right, let's make burgers. All right, MRI. What's your best test to check for ligamentous injuries? That's the MRI. Okay, most sensitive and specific. I know you guys love sensitive and specific. That's a topic you relish. But just understand that this is the confirmatory test. That's more so what we think of. Okay. So ACL rupture. This is actually a really good picture. If you look there, it looks like all those fibers are running continuously, right, in that oblique nature. And when you look over to the right, it looks kind of ratty, right? Almost like chewed up. okay? That's evidence that there's an ACL rupture, okay? And that sagittal view, I told you, is a good view to check and see if the patient has an ACL tear. Good to go? Does everybody see the ACL rupture on that image? Of course you do, okay? And you would agree that this is a T2 image. And so what is this one? T1, right? You guys remember that from radiology, correct? Okay, everybody's smiling. Some people are laughing. Okay. I would say that you should get pretty decent in your practice at taking this out for MRIs. If there's one view you're going to look at, it's this one, right? For ACL, and we'll talk about meniscus later. But how are you going to get good at it?
By looking at a lot of the.
By looking at a lot of them. That's right, Mr. Deloach has answered triumphantly, and he is correct. Okay. I also see a question living. Yes. So, adverse outcomes disease. So this is when we talk about those three characteristics, right? I talked to you guys about orthopedics. How do I think? I walk in a room, I'm thinking three things when it comes to knee injuries. Pain, instability, or pain with instability, correct? So if they go on to have an ACL rupture and it's not treated, they're going to have chronic instability. Chronic instability in walking on uneven ground, right? So they're trying to go on a rut march with a pack on, they get on uneven terrain and they're having difficulties, okay? And or pivoting, planting, twisting, turning activities, correct? So that's what we're talking about with chronic instability. So we did also talk about how meniscal tears live with ACLs, right? With the ACL injuries, correct? So which one was it, medial or lateral meniscus that we talked about with acute ACL ruptures?
Medial.
Medial? You are correct, ma'am. Acute ACL injury equals medial meniscus tear. Right? If that was a male, I apologize. Okay. I can barely hear. I'm all stuffed up. So, and then osteoarthritis. So why do people get osteoarthritis from chronic instability? Because they have instability that causes the wear pattern of the knee to change, correct? So it's like that mortar and pestle, but now you have instability as well, and it grinds and it causes progressive degenerative changes, which is the very definition of osteoarthritis, correct? So treatment, non-operative. So first we'll talk about the patient, right? So young, active, male, females, right, that want to live an active lifestyle, do they require an ACL? Yes. Old dudes like me, right, our day is come and gone, okay, our glory days, if you will. So if it's a young person, you're going to lean more towards operative, okay, especially if they're active duty and they live or they have a very strenuous job, or they're trying to go for some high-speed stuff, right? But older, right, or less active patients, as I said, they're on the bottom left, that's your non-operative, okay? So what you're going to do is you're going to send them to physical therapy, right? That says rights, activity modification, all that. With physical therapy, and what kind of stuff are you going to tell the physical therapist to do with it? Stabilize, okay. Strengthen the muscles, improve flexibility, improve range of motion. You were correct, sir. And hamstring strengthening, right? That's going to be your key. Hamstring strengthening, excuse me, and quad strengthening, okay? So you want to improve flexibility as well. All right, so everybody thinks to themselves, right? Who has had an ACL injury in here that wants to share? Anybody? You either haven't had one or you don't want to share. You're not very giving, right? But if you have an ACL, you know somebody's had an ACL injury, correct? Yes? Okay. You've heard of it. We all know. Okay. Did they die? Yes. Not from the ACL injury, right?
They did.
I usually have somebody, it's a bigger laugh, right? One person that's had ACL reconstruction. But it's not something that's life-threatening, correct? So do you have to do all these heroic measures where you put them on crutches forever? No. The concept is always, what is the enemy of orthopedics? Stiffness, right? So we want to get them moving, correct? As long as you're walking in an inline fashion, okay, they shouldn't have any issues, right? Once that swelling goes down and the strengthening occurs. And so basically the principle is, even though it says they're used to crutches, knee immobilizer, or range of motion brace, okay, you want to get them out of that as soon as possible, okay? Don't forget about those things, okay, because if someone can't walk, you do give them crutches for a short period of time. Yes, sir. So he asked, what's the difference between a range of motion brace and an ACL functional brace? So a range of motion brace, have you guys seen people walk around with those big braces and have a little dial looking thing on the side? Right, it has different degrees of range of motion. So the range of motion brace allows you to set that, okay? You can set the range of motion that you want the patient to have. Good to go? So initially, you can set it at straight. What is straight? 0, correct? Okay? So you can set it not just to 0, not just to 30, but you can set it from 0 to 30, for example. Okay? You can set it from 0 to 90. Or you can set it to 3. Does that make sense? Okay, so that's a range of motion brace. So it's highly functional. It's used for many different injuries. Okay? If you have a multi-ligamentous injury, that sounds pretty good, right? Once you get the knee stabilized in a position, you can lock it in there, right, and let that swelling go down. Let physical therapy work with the patient. Okay? And then an ACL functional brace, okay, is literally a custom brace, because everybody in here is a little different, right? Right? My thighs are not as robust as some other people's, correct? So it's measured, right, in a couple different areas, both proximally and distally, and it's literally custom to the patient. Okay? Are there off-the-shelf ones? Yes, they don't work as good. But an ACL functional brace only limits, excuse me, what does the ACL do again? What does it prevent? And rotary, correct? So it's very limited. So that's why it's called ACL functional brace. So even if someone gets treatment for an ACL injury, right, after they get treatment for it, you can give it a custom ACL functional brace, right, when they're going to do certain activities that put them at higher risk for repeat ACL injuries, for example. Does that make sense? Did I explain that good enough? I don't really know what I'm saying, so. All right, so if they get a big swollen knee, is there blood in it? Yes, right, that's called a hemothrosis, correct? So if it gets big enough, we do consider tapping it. Okay, but I'm just telling you right now, do you ever want to go, we are not invited? Negative, stay away from it, right? So if you can get the swelling down with just physical therapy, diffusion therapy, right, they have different modalities you can do to get that swelling down, that's the way to go, okay? But if it gets large enough and painful enough, we can do a tap on that, right, to relieve pain, so we consider it. But how many times have I done it? Limited number of times. Does the risk of infection outweigh the benefits? That's what you have to ask yourself. Does that make sense? Okay, and so when we talk about operative, we're talking about reconstruction, correct? We talked about this before. We can go through this pretty quick. But ACL reconstruction is basically what God gave you, or whatever you believe in, right? Then you are, if you're going to reconstruct, it's because you can't use what was there before, correct? So you have to add something, okay? So when we talk about those grafts, right? We talk about the ACL autografts and the ACL allografts. Autograft is you, for the patient more specifically, the last sheet. And then allograft is a cadaver tissue. Looping things back, do you remember the goose-like foot? Metaphyseal? Yes. And the 3 tendons? Oh my good. Gold star, sir. Okay. So, yeah, I would be more excited if I could see clearly. But good job. So, well, you can use those to what? Fashion a new ACL, correct? Does that make sense? Okay. We can also take patella graft. That's what happened here. The patella, right? Patella, tendon, and then what? The proximal tibia. You can take a graft that has bone on both ends too. That's all that picture's showing there. I don't care that you know the surgery specifically, but I do think it's important for you to know. She's rising. Yes. So I do think it's important to know what an autograft is and what an allograft is, correct? So, okay. Any questions about auto versus allograft? Okay. Do we do ACL repairs? How commonly? Not commonly. We do reconstructions. So don't fall for that trap. Okay? Don't fall for that trap. Because we're going to talk about healing of those reconstructions here in a second. And it's very uncommon to do a repair. Because a repair is taking what God or whatever gave you and repairing it, correct? Not augmenting it, not replacing it, but just repairing it end to end. That's not very common for ACL. I've done one, or been a part of one, I should say, in my entire practice. Okay? Makes sense. So again, you should lean more towards thinking it's a reconstruction. So if you think it's a reconstruction, do you think you have to protect that graft? Yes, because as that list there says, yeah, infection, we always worry about infection. But graft site pain, okay, why does it say graft site pain? Does that look like if you take a piece of that bone, sorry, I gotta use the side. That bone right there, and that might be kind of painful. Okay, if you've ever broken a bone, you know bone pain sucks. Okay, and then also we put a bunch of poke holes, sometimes we do open approaches. Okay, so we make big incisions, okay? So it's not painless, correct? So graft site pain is very common. For bone, patella-tendon bone reconstructions, it's the most common complaint. I tell patients if they elect to do that kind of graft, because the patient has a say in this, correct? All right, we don't have to do hamstring. We can do bone, patella-tendon bone. We can do quads. We can do all kinds of different tissues, right? If we take it from them. If we take it from a refrigerator, right, or a freezer, we have even more choices, correct? That's an allograft. But I tell them if they choose to do that bone, or they take a little piece of that bone, anterior knee pain is very common. So when they come see you post-op, and they're 6 months post-op, and they say they still have anterior knee pain, you think to yourself, what? It's from the donor site of the graft. Everybody understands what I mean by donor site? Where we took it, right, to do the awesomeness. Failure of the incorporation of the graft. So let's think about this real quick, right? Especially if you use allograft, right, because it's not the patient. There's a lot of, sometimes that we're very, very concerned about the ability of the graft to incorporate. What does that mean? It means heal in, right, and provide stability. That's all that means. Okay, so we have to protect the graft while it's trying to incorporate and not have the patient push too hard. Does that make sense? Do you think after an ACL reconstruction they wake up in a range of motion brace? Yes. Yeah. Oh, the answer's yes. Yes. I don't know if you say no. The answer's always yes. So we set that to a certain degrees, right? And we even protect it even more if we do an ACL reconstruction with also a meniscal repair, right? Meniscal repairs are common. It is common, sir. Hopefully. So he asked, will the osteoblasts do what they do? I hope so, right? But what if the patient is a chronic smoker, alcoholic, right? Especially a diabetic. Ooh, right? We start looking at those X-rays about 60 feet away, and we're like, that looks pretty good, right? Then we take 5 more steps back, and we're like, yeah, that looks really great, right? Because their comorbidities sometimes will cause them to not heal that graft, and the donor sites, and the incisions. Does that make sense? So patient selection is paramount. Okay. So another reason why we might not do ACL reconstructions in older patients. Okay. You would tell them and say, well, you got to quit smoking before you even consider this. Make sense? The concept is, you should remember, right, is that the second surgery is never as good as the first. So if the patient has ACL surgery, doesn't incorporate that graft, doesn't heal it, and what? It re-ruptures, as it says there, the second surgery is never as good. Does that make sense? Okay. So we want to give it the best chance to heal. And secondary osteoarthritis, several decades after the injury. But Major Douglas, you said that they're going to get arthritis if they don't get an ACL reconstruction. Now you're telling me they're going to get arthritis if they do get an ACL reconstruction. Yes, they're both true. Okay? So we counsel patients on that. So when we give them the graft, are we trying to prevent osteoarthritis or are we trying to provide stability? We're trying to provide stability, correct? So we do these angles and these measurements. It's very complicated. But if you look here, these angles, that angle that graft is in, everybody sees this graft here, right? See it? Okay. It's going obliquely there. Okay, from lateral to medial, or medial to lateral, depending on how you look at it. Okay. So when we do that, can we perfectly recreate that angle that they had from birth? Not always. Okay, so they wear unevenly still. Okay, but we provided them stability. But we always counsel the patient that they're going to get osteoarthritis. Okay, makes sense? So if you tell somebody they're going to come and get an ACL reconstruction, and I'm going to make them 100% pain-free, I will find you. Okay, because that's not true. Makes sense? Especially if they have donor site pain, right? Trying to incorporate all these concepts. Okay, we'll go a little faster now. So referral decisions, well, patients with continued laxity, if not the surgical candidate. Okay, well, why would you send somebody to orthopedic surgery if they're not a candidate for surgery? Will they benefit still from a custom ACL functional brace? Yes, that's something what our specialty provides. We have contracts, we have relationships with these companies that do these measurements and provide these graphs, okay? So if they are a surgical candidate though, we will give them the business, okay? So gross knee instability, that's an immediate referral, right? That is a red flag. If they had a multi-ligamentous injury and have gross instability, does that look stable there in that picture? Ew, that looks unstable to me, right? And so therefore that's more leading towards a knee dislocation. How common are knee dislocations in the absence of high energy injury patterns? Not very common. Okay, it has to be a high speed or high energy pattern. Make sense? Does your knee have a bunch of knee stabilizers? Yes, we talked about that. The reason that the Lockmans can be more beneficial because when you're doing the anterior posterior drawer, those secondary stabilizers kind of take over too, right? So high energy injury patterns, right? So car accidents, okay, major falls from height. You know, the leg got caught in something and twisted and pulled, right? Things like that. Okay. Knee dislocation. I'll give you a story, right? Hope I remember correctly. I was at Portsmouth. I was 6 months into my fellowship, and got a call from the ER saying they had a knee dislocation. I said, "You gotta be kidding me." No, you don't. You have a patellar dislocation, right? No, this guy legit had a knee dislocation. He was at the trampoline park, right? Orthopedics loves trampoline parks, right? We get a lot of repeat customers from there, and we love it. Okay, when a new one opens up, we start licking our chops, sharpening our knives, right, and getting ready. Okay, so this guy decided, right? This is not a small dude, by the way. I can still remember his face. So, and his body had this. But he went to the park, right? And now at these trampoline parks, they have basketball. They can play basketball on a trampoline park. So he went up. I don't know what he did, right? He's a big dude, came down, twisted, turned, God knows what. But he was up. You know, he got some ups from that trampoline, okay? So when he landed, all kinds of badness happened, okay? And he said, yeah, they had to relocate me. I was like, no. He had a patellar dislocation, right? That's more common, right? People say knee dislocation. It's a patellar dislocation, not serious, right? But he had video while they were reducing his knee, the firemen, the paramedics, he was shooting a video, right? Craziest thing, right? So apparently he actually has a high pain threshold. When patients say that, they normally have to say, no, you don't. Okay? I'm like, no, you don't. We don't have what you sleep. But he had a video of them relocating his knee. So I was like, oh my gosh. So do you think he left the ER in a range of motion brace? Yes. Well, that's true, right? As big as it was. So he went on to do well, I think. I don't remember. Right? So when you're in residency, fellows, and you're phase 2, you don't track patients to a certain amount, but there's 1,000 patients in that facility, right? So you lose sight of some people sometimes. But this guy had a legit multi-ligamentous injury, okay? A true dislocation, okay? So what artery is at risk? Okay, don't forget that. Okay, any questions about ACL? What's that? You have a question? Yeah, sorry.
On the Sagan fracture, doesn't the ACL
Oh.
holds the lateral side?
Yes, that's a good question. So his question was, you're looking at a Sagan fracture, that's a lateral tibial eminence, correct? So is that evidence that there was a rotational force there? That's what it is, that's your answer. Okay. No, it is, but they go together. Okay. When you have that strong, when you have a strong enough force to, it's not the ACL, right? Because that's the interior what eminence? What's this area here called? Remember we talked about it. Okay. I would find out what that area is called because that's where the ACL is, right? That's where it lives. Okay. So if you see a fracture there, it's also an ACL injury. Makes sense? Because that's where it is. That's where it lives. Okay. But the point being, when you see this fracture pattern, this is an evidence. It's evidence that there was a strong rotational component to this. Therefore, the ACL gets torn. That's what you're saying. Okay, that's the simplified way of saying it. If you want the pathophys thing and the biomechanics thing, I'll give it to you on a break, okay? And then I get all excited, tell me to stop talking. There's a lot of forces there that are measured in newtons, okay? But that's your basic nitty gritty, okay? Did I ask you a question, sir? That's a really good question. Okay. Excellent. I like that question. Okay, bursitis of the knee. By definition, we know what bursas are, right? Skin, tendon, bone, provides padding, provides decrease in friction, okay? So we have bursas everywhere in your body, a lot of different places. We talk about greater-trophic bursitis. When we're talking about this area, though, we're talking about knee bursas, okay? We really only concern ourselves with the popular, okay? But as you can see from this picture, there's a bunch of them, okay? So the prepatellar bursa, that's here, correct? Right? What is this one again? It's the medial one. Is that Gerdes or is that the pes anserinus? Pes anserinus. Also a bursa, correct? Okay. Good to go? Okay. So when we're talking about bursas, we talk mainly about the prepatellar bursa, right? So think about this. You can feel, if you feel your kneecap, right, is that real superficial? And the bursa is over that, correct? So even the smallest degree of trauma can cause an open wound that tracks down to the bursa. Make sense? But the other ones are just a little deeper, okay? So anterior aspect of the patella, septic bursitis is possible. Okay, again, if you get open injuries. What's the most common again? What's always the answer? 50, 50, 80, 20, right? That's the one. Okay, so Staph aureus and Strep species. Okay, so skin flora, correct? Okay, pes anserinus bursitis, again, that's the insertion site of the hamstring medial tendons at the medial tibia. Okay, so you need to understand this concept. In patients with medial compartment osteoarthritis, the pes anserinus bursa is very likely to get inflamed at some point. Medial compartment osteoarthritis, pes anserinus bursitis go together. Okay, when you have medial compartment osteoarthritis, we talked about this, right? Loss, LOSS. So you have a loss of that space, okay? That intra-articular space, right? So that's when you have that collapse, correct? That's when you start having that bone making contact with other bone because the cartilage gets worn down. So when that happens, the pes anserinus bursa also gets angry, okay? Make sense? And the other thing you'll see commonly is in long-distance runners, or just runners in general, right? You don't have to necessarily go distance, you can also go in speed and intensity, correct? Alright, just looking at this picture here, prepatellar bursitis, does that look pretty nasty? Alright, looks kind of angry, okay? But is that serious? Alright, can the bursa get that inflamed and not be infected? Possible, okay, because it's real superficial, correct? Alright, but should you still work it out and see if it is infected? Yes, okay? It's, the patella is intra-articular on the undersurface, not the anterior aspect, right? This is a more superficial aspect. But if it tracks all the way down, then it could involve the knee joint, okay? So you're looking at pain with activity or direct pressure. You're looking at localized swelling. You could have gross deformity, correct? That's what that picture is showing you there, all right? So then we move on to pes anserinus. Sometimes it can be confused with a medial meniscal injury specifically. It says meniscal injury, but medial meniscal specifically, right? Does it all kind of live in that medial aspect of the knee? Yes, right? So your differential diagnosis is now expanding, correct? So pain is distal to the medial joint line though, okay? So if when it comes to that palpation thing, where you guys do your sparkle fingers, or your twinkle fingers, right? Your palpating thing, and you're saying you're doing things, and your fingers are moving all over the place. You got to find the medial joint line, find the lateral joint line, and figure out if the patient's pain is at the joint line, or if it's more distal or more proximal. Does that make sense? So in this case, the pain is what? Distal to the medial joint line. So that's going to be a big clue as answering. Okay? And you must rule out septic. Okay? You must rule out a septic joint whenever you're concerned. You guys know my paranoia, right? When you call me and tell me a patient has knee pain, I'm going to ask you on the phone. You know, so you don't think it affects you, right? And you're going to have to be able to answer that question. All right? So you need to examine the patient and see if there's any signs. What are the signs? Red, hot, swollen joint. refusal to bear weight, correct? All right, that's what we're talking about. All right, physical exam. So if you have tenderness there, then it's the bursa. Okay? Duh. So prepatellar bursa, the patella may not be palpable due to the swelling. So if you have a big swollen knee like that, you may not actually be able to feel patella, right? Because the prepatellar bursa is swollen. Pes bursitis, okay? Numbness distal to the patella due to compressed saphenous nerve branch. Is that in bold gold? Oh, it is. So I would know that, okay? Because that's what you're talking about. Patient may actually report that they have pain distal to the medial joint line, they have tenderness there, and they can say when the swelling comes up, right, because of runners, for example, they have some numbness distally, okay? And that's due to that saphenous nerve branch compression. We understand that concept, correct? That compression of the nerve. Septic. There it is. There's your definition. Okay. Oh, let's go back here. So you guys see this bursa there, and you see the swelling that's more proximal to that. So here's the swelling that's more anterior to it, and there is the infected bursa. So it may live a little deeper, right? So do you have to do light and deep palpation? Yes. Don't just touch it a little bit, sparkle fingers, right? You may actually have to use your thumbs and kind of work your way in there to see if they have pain more deep. Okay? It's a technique. Okay? So radiographs-wise, why would you get radiographs? Because again, you're looking for acute osseous abnormalities and or malalignment and other findings like retained foreign bodies. If somebody falls in an industrial area, can they get little pieces of metal stuck in their open knee wound? Yes. So you're looking for things like that too. Retained foreign bodies. Makes sense? You got to get that out of there. So at a minimum, you're going to do AP and lateral views, correct? All right, because one view is no view. Laboratory-wise, if septic bursitis is follow me here. If septic bursitis is suspected, you're going to tap the bursa. You're going to do an aspiration of bursa. If septic joint is suspected, you're going to do a joint aspiration. So in any, like we talked about olecranon bursitis, in any case, should you go to stick a needle into the bursa and go all the way down to the knee joint? Never. Okay, that's what you want to avoid. Okay, so if you have to do a tap of the bursa and a tap of the knee, you may have to do two separate taps. Does that make sense? Okay, so when you're reading questions on pants, make sure you discern which one it is it's asking you about. Okay, good to go? Okay. So one of the things we do, gram stain culture, cell counts, microscopy, right? Is the knee joint involved with gout? Yes. Yeah, can be. Okay. So gout is your differential too. And you'll do a synovial fluid analysis. Okay. Everybody sees this draw here. Okay. See how they're going from that lateral to medial angle there. Okay. You think they're going into the bursa or to the joint? Joint. That's a joint aspiration. Okay. Because wouldn't the prepatellar bursa be more distal and more superficial anterior? Okay, makes sense. So this is a very common position. When you guys go to phase 2, you may see the provider put the patient in this position, slightly flex, and go from the lateral aspect, right, and insert the needle into the pouch. Okay, the suprapatellar pouch, and that is continuous with the synovial joint capsule. Good to go? Does that look like normal fluid that's being drawn from there? Straw-like fluid? Yes. All right, that looks pretty normal. But that doesn't mean anything, right? You gotta still send it, okay? So if you stick the needle in there and you're getting resistance, you're trying to pull with all your might, right? You're just not getting anything. Reposition, right? Because you could be, as that picture is telling you there, you could be sticking that needle into that adipose fat tissue we talked about before. Make sense? Okay, so you could be trapped in some fat. Is fat normal there? Yes. We talked about that. Okay. So adverse outcomes of disease. So they continue to have bursa. They can have chronic pain. They can have what? Weakening of surrounding structures like tendons and ligaments, and continued pain due to that pressure. Make sense? Okay. So you could also have septic spread to the knee joint. So if a prepatellar or a pes anserine bursitis gets infected, is infectious in nature, excuse me, and then it goes on long enough and it tracks into the knee joint, you got a whole other set of problems. There we go. Okay. So we talk about rights, right? Rest, ice, compression, elevation. So there's a picture there of the compression using an elastic bandage. Okay? So as you compress to the point where they can't feel their toes, ooh, that's too much, too tight, loosen it. Okay, so after you apply that, you ask them, you guys know how to do your distal neurovascular exam, correct? Saphenous nerve, sural nerve, tibial nerve. Of course you do, and if you don't, we'll get to it more. Okay, but that's basically what you're going to do. I'll teach you a couple of little tricks so you can do it quickly. Okay? Nobody wants to watch you do your cotton wisps and all that. You know, yeah, you're going to do that for your OSCE, right? When you're in practice, you're going to get down to it. Okay, good to go? All right. So non-infectious bursitis. I allegedly made edits to this slide so you could see, right, that there's a difference between non-infectious in nature treatment and infectious in nature treatment. I would focus on that when you study. Okay? So non-infectious, you could potentially, after you do all your NSAIDs, RICE, activity modification, PT, compression with that bandage, right? You could consider doing a steroid injection, okay? But does bacteria, does infection love glucocorticoids? Right? So should you ever put a glucocorticoid into a suspected infected knee? Negative, right? So again, you want to rule that out before you consider that. So then if you go down to the bottom there, your thing is septic bursitis, early, mild, right? Or superficial, not continuous with any other structures, right? You could consider doing oral antibiotics, okay? More severe though, IV antibiotics. Whenever you see the word IV antibiotics, guys, on pants, is that patient in a hospital? Yes. Yes. At a minimum, they're in the emergency room, correct? And then they're transferred to the floor, right? My father just got admitted. Took them like 4 hours to get him up into a room, right? Doesn't matter who you are, right? It takes time. But IV antibiotics, that is the signal that you're admitting the patient and you're monitoring the patient, right? Because if they go on to have surgical indications, like it says in the bottom there, what's the surgical procedure? Excision and drainage, right? Excision and drainage, IND, okay? Right? Often not required unless it's more severe and or there is what? Blushing. Evidence of joint involvement, okay? I apologize. So adverse outcomes of treatment, NSAID risks are always there, okay? When it comes to bursitis, do you think you should be using like strong NSAIDs to start with? No, right? You should start with the Votrins and the naproxens and things like that. But if, like I told you guys before, if you go on to the bigger guns, diclofenac, Celebrex, things like that, you may start experiencing some more risk side effects. Okay. So if you're injecting in and around the pes anzarine, that's the goose-like foot, or those three tendons that gentleman over there told us about, right? So if you keep injecting in that area for pes anzarine bursitis, can you weaken that attachment point there? That insertion point? Yes. So you could potentially get a rupture. You don't want that. And infection from aspiration or injection. That's a red. It's in red, correct? Yeah, I tell you guys my story about the guy with the olecranon bursitis. They ended up getting admitted, had necrotizing fasciitis. I didn't tell you that story? No. Okay. I should have some other day. But basically, what it was, because I'll tell it wrong right now. But what it was is they kept trying to tap the bursa, and at some point they went all the way through from the bursa into the joint. Okay? Dude ended up getting a raging infection, got full septic, okay? Never regained consciousness the whole time that we were treating him. Okay? We had to go in there and just open everything, fillet everything on. Right? Just open everything up and all the way down. From the back of his scapula down to his fingers. Okay? So it's badness. So when I'm telling you that, I'm trying to scare you a little bit, but appropriately, right? You should have a respectful level of fear. Okay? Because you need to understand that even if you don't see infection, it sees you. Okay? So you don't want to let it get to you, right? More importantly, you don't want the patient to sustain subsequent sequelae. So if you don't know how to do a proper bursa aspiration, refer it. Make sense? Okay, if you feel comfortable with it, okay, good to go. Okay. All right. Red flags. What's the one thing in red there? Recurrent. All right, so it keeps coming back. So what are the risks here? This prepatellar bursitis, correct? So Pez ring goes more with runners, right? Long distance runners, okay? Motormen, do they very frequently kneel? Yes. Infantry guys, do they very frequently spend time on bent knee? Yes. So in certain career fields, you see that. So if they go on to just not be able to heal it because it heals, and then they go back to full duty, and then it opens up again, gets inflamed, and you're like, okay, aspiration. So eventually, if it goes on long enough, you may have to consider operative treatment. Make sense? And all the rest of this is a repeat. Okay? Any questions about any of that? Okay. You guys mind taking an early break? I think I need to hydrate. Okay. Is that okay? All right, let's come back. 5 till.
Switch these. He knows. 26, 21, ready? 21. 11. I don't know what to do all that.
Ask all the questions.
Test is, throw test is like, say Friday, we Yeah, I've never worked with them either. I mean, like, I don't know. It's like if my feet take out of It's not project here. This looks pretty good. It's not that good, but it's pretty good. You do have time. So, is that because it's so cold you got it so early? Pressure makes time. Sir, I'm gonna get let's make burgers with meat. Did you see that line before? That was pretty fire. Pretty good. What's that?
So, I don't know what this is. But I did.
I was stuck on it because I was like, I didn't know. I would have. I'm glad you didn't ask me.
How many burdens? They'll get these towels.
I've been trained for this.
Took me like 3 weeks.
open that can here. Just open it. Could be a second one. What's it called? Oh, I don't know. Like, you tried it. I didn't really think you were getting 100, bro. Yeah,
I laughed when I heard that. Except for that. Because it wasn't just me, it was like, waiting until everyone logged in.
I usually be in the force when I saw how long
Okay.
What's the next race?
This weekend, you want to Oh yeah. She says she drives like you're talking about like stuff like Ortho and stuff. She's like a partner. Stuff like other people. Like a partner.
Sets my wife. Especially for those kind of players. She might get pissed.
yeah, so right now.
Well, honestly, I'm studying narrow. Like I'm probably more kids than narrow.
Right before you, I think they're made. He loves the races. He has a same. He has a same in his house. That's why he's so good. He's like non-stop. After well, even like
Alright, you guys ready?
Ready?
Let's get it. Alright, so the next topic is claudication. Right? I will tell you that this neurogenic claudication, I get it, the vascular claudication is thrown in here as well. So just pay attention to that, right? You guys should have talked about vascular claudication type stuff in cardiology. Question mark?
Yes, sir.
Okay, alright, good. But again, it gets thrown under MSK because it's kind of in a differential for neurogenic claudication. Don't overlook this topic. If it's been a minute since you've looked over stuff like this, please take a minute. Okay? This is a heavily tested area, allegedly in hands. Okay? So when we're talking about, excuse me, neurogenic versus vascular, it's neurogenic meaning from the nerves, right? Nerve roots, nerve root compression. Okay? And then vascular meaning vascular. It could be small vessels, large vessels, etc. Usually we're talking about distal, more peripheral. Okay? Compromised arterial flow. Okay? The big thing that it seems like they focus on is that I think I'm losing my voice. is that they really do give you activities. Okay, they give you a vignette, a scenario, a stem. It gives you an activity, and it gives you symptomology. It gives you what the patient says. Okay, so in that effort, I gave you this. You're welcome. Okay, because this is a nice little way to kind of look at it and say, okay, when you're talking about walking distance, right, what's vascular versus neurogenic? When you're talking about palliative factors, what makes it better, right? What makes it worse? Then you have the answers for neurogenic versus vascular. Okay, so take a minute, right? Don't memorize this chart. Just get it in your head, kind of what it is. Okay? Okay, how does this patient present? Okay? So see the bottom there where it says pain characteristics? Okay, again, is vascular more numbing, aching, proximal to distal, or is that neurogenic? That's neurogenic, correct? So that's an example. If they give you a scenario that gives you that, you want to make sure that you key in on that, okay? Does neurogenic have anything to do with open wounds, things like that, hair loss, things like that? So there's an example of how you study, okay? By the way, Mr. Avila, I have an answer for your question from the other day. If you don't mind, I'll save it till next class, right? So I can actually speak and remember what I said. Okay, so physical exam, neurogenic, well, you're going to do a neurologic exam. So they're going to give you a neurologic exam, okay? If you have normal findings, is it neurogenic? No, so don't miss that low-hanging fruit, okay? Look at the vignette, look at the stem of the question, and pick those things out. Weakness and reflex changes after provocative activities. There you go. They're going to tell you the patient has a increase in their neurogenic type symptoms and decreased reflexes, okay? Versus vascular, which is pulses, which is cool extremities, which again is those wounds, right, ulcerations, with decreased healing. Another thing again I'll throw in there is that hair, right, hair tends to be sparse in vascular claudication, okay, so kind of peripheral vascular disease, okay? And then, would you ever do a ABI for neurogenic claudication? No, right? Unless the diagnosis is unclear. But if you know it's neurogenic, that's not when you would do an ABI. You guys know how to do ABIs, correct? Okay. Have you ever done an ABI? Like actually done it with a Doppler ultrasound, a little portable. Okay. This is what I'll tell you. When you guys get out in phase 2, I don't have one here that I know of. If I can find one, all right, let me know if you want. I can demonstrate it. Because very commonly people say they find the pulses. Bunch of liars. They don't. Okay. Because finding them should be easier with a Doppler ultrasound with a portable, but they just put the probe in the wrong place, and they think they hear something. It's like that hearing test you take when you join the service, and then later on, you just keep pushing the button. They're like, sir, why are you pushing the button? Right? And I'm like, I hear sound. He's like, we're not making it. We're not even starting the testing. Okay. So, anyways, I'm going. So, neurogenic collocation, disc space, and canal narrowing. Okay. So that's it. What's this view again? Axial cut, and you can see that nerve root exiting compression, right? Exiting nerve root compression. And then over here is the ABI, okay? So ankle brachial index, systolic blood pressure at the ankle, systolic blood pressure at the brachium, utilizing a Doppler ultrasound, right? Then you do a bunch of math and decide, what's normal? It's in bold gold. 0.9 is abnormal, right? So anything above 0.9 is normal, right? Right? Remember, you can't, the difference between negative and positive, right? Like when we talk about DEXA scans, right? So focus on that, because if it's 0, it says 0.8. Is that normal or abnormal? 0.856. Okay, good. You see where I'm going with this. So what you want is 1 to 1.1, but again, if it's goes in the other direction, that's when it gets confusing, but we won't go there. I don't know if you did in cardiology, but we won't go there, okay? But ABIs, just know that 0.9, less than 0.9, excuse me, is abnormal, okay? Less than 0.9, less than 0.9. Moving on. So when it comes to vascular claudication, arterial insufficiency equals progressive ischemia, right? Which is bad. We decided that, right, when we were talking about the Farber syndrome. Okay? And if it's bad enough, it leads to limb loss. Okay? All right? Now, the thing that students want to do is they want to say that every patient that's vascular claudication is at risk or limb loss. Is that true? Does every patient with vascular claudication go on to lose limbs? Yeah. Okay, so just to tell you this, when you think about things, right, you have to think of things as a continuum. Okay, so over here, normal, over here, way abnormal, limb loss, but most patients live somewhere between my hands. Make sense? Somewhere in the middle, okay? But why would you get the ABIs? To see where they are. Make sense? Why would you get repeat ABIs? To see if they're getting worse. Does that make sense to you guys? Okay, so don't just circle the answer that says surgery for everybody, right? Look at the question and see, is this severe? Is it moderate? Is it like, okay, intermittent, occasional symptoms, and the ABI is normal? Don't just circle surgery. Does that make sense? Because that means you're not understanding that concept I just described. Okay, good to go? And don't get it wrong in practice. So non-operative or neurogenic, okay? We talked about those ESIs, right? How many are you going to do in a 6-month period? No more than, I told you the rule, right? 3, 6, 9, 12. You're only thinking 3-month intervals. 2, 4, 6, 8, right? Is it ever 10? No, it's never 10, right? So 3, the answer is 3. Okay, make sense? No more than 3 ESIs. Okay, and if you do 1 and it gives them 0% relief, let's talk about this. You guys are thinking, you're critical thinkers now. You do 1 and it gives them 0% relief. Would you do another one? No. That's why you look back at the radiology report and see if it says they had a successful injection into the epidural space. Because if they did, that means it went where it was supposed to go, and it didn't work. Make sense? All right, good to go. So vascular, meticulous foot care. Meticulous foot care. You got to take care of those feet, okay? Right? Change your socks, or else with dirt in it. Nah, it's more than that, right? Because you're, in this case, you are talking about well-fitting and protective shoes, okay? Right? So do you want tight shoes with a small toe box? No. You want well-fitted, wide shoes, right? That aren't causing compression. Does that make sense? Okay? And that don't cause the patient to experience any kind of fasciitis, etc. Another concept I put in bold gold here is that you want to avoid elastic support hose, right? Does that make sense? Yeah. Does that make sense? Because the elastic support hoses, right, that's for those post-op patients. Okay, in this case, if you put those elastic support hoses on the patient, is it going to cause more compression? Yes. Isn't that the problem? That there's arterial insufficiency? So are you making the situation worse? Yes. I'm pausing for a reason, guys. There's vascular claudication, you do not use elastic support hose. Okay? Don't get that wrong on the answer. Okay? That's the one that's like, oh, that one stands out. Yes, it's also the wrong answer. Right? So operative, neurogenic, we're talking about spinal decompression and or fusion. Vascular, that's when you start doing all those graftings, right? Arterial stuff. Is that ortho? No. Why is it on my slide deck? You're welcome. I don't know. But I'm talking about it, right? Because if I find somebody who has arterial insufficiency, do I do anything with them? Nope. I refer them. It's the same thing with you. Especially if you get your ABIs and they're less than 0.9, correct. And then, but if they have advanced limb-threatening claudication, then they have to get surgery. Make sense? If it's occluded and it's getting 0% blood flow acutely, you got to get some blood there, correct? Otherwise, the limb could die. The foot could die in this case. Okay. All patients neurogenic, orthospinal surgery, vascular surgery. Vascular surgery. Okay? Any questions? That's it. That's claudication. Okay, make sure you spend some time on it. That chart, I think, is time well spent. It'll help you study faster, more efficiently, I should say. Collateral ligament injuries. So, are the collateral ligaments intra-articular or extra-articular? Extra-articular, correct? The cruciate ligaments are intra-articular. Okay, intra-articular. Okay. So in this case, we're talking about the MCL and the LCL. This is a concept you got to get in your head. A valgus abduction force puts the MCL into risk. Okay, the book describes it as both. We usually say a valgus moment. or valgus motion. Okay, that's how we describe it in ortho, but it's also abduction. I'm not sure that translates as well. But it's a blow to the lateral knee with a planted foot. So the foot is planted, the helmet hits the side of the knee, bless you, and it causes a valgus moment, right? Which stresses the MCL. Good to go? And the LCL is the opposite. That's a varus force or an adduction force, okay, that puts the leg into a varus moment, okay, and puts the LCL at risk. Okay? Now we understand that the LCL doesn't go condyle to condyle, right? The LCL goes from the neofemoral condyle, proximally, down to the fibular head, right? We talked about that in the anatomy, so don't get that wrong, okay? So here's that term again, posterior lateral corner injury, right? That's not PCL, that's PLC, okay? So that's completely different. Bunch of structures there in the posterior lateral corner. Don't really get into it too much. I need a whole other lecture period to even do any level of justice. But just understand if somebody has a PLC injury, right? We're talking about the popliteus tendon, the popliteal ligament, the biceps femoral tendon, and some other things, right? Then you're concerned about gross instability. Okay, so if you're concerned about gross instability, is that surgical? Yes. So an LCL injury that's also associated with PLC injuries, whatever it is something that needs some time, some attention to from a surgical evaluation. Okay, you guys know what foot drop is, right? Okay, so right there, approximately at the fibular head we were just discussing, right? There's compression there, and they have the peroneal nerve is compressed, and the patient can experience some kind of foot drop. Right. So like we just talked about, the proximal fibular head is on the lateral aspect of the knee. Right. So anytime you suspect the patient has an LCL injury, you need to do a full assessment, right? Make sure you do a full neurologic assessment, neurovascular assessment. Okay, good to go? Any questions about that? And this is, I thought this was a good picture, right? It shows that force, okay? And it's talking about either it's MCL or LCL. So take a moment with this, make sure you understand this. Make sure in your mind, you can recreate this when that test is in front of you, okay? You can associate these forces and what ligaments are being stressed, okay? Any questions about this? It's just a representation. I know I like pictures, right? So it's already colored for you, sorry. So clinical symptoms, many can return to play. Okay, why is that important? Because an ACL, PCL injury, do people normally return to play? No. So that is, specifically ACL. So that's an important factor I told you with your history, correct? Right? So when you're reading vignettes, again, when you're reading questions on PANCE, and soon, right, a couple weeks, in this classroom, look for things like that, right? But these patients can return to play, okay? Because are there other structures that also provide stability? Yes, okay? Swelling or stiffness with pain along the affected ligament, okay? Remember, the ligament starts proximal to the joint line, it ends distal to the joint line. So if they have joint line tenderness specifically, joint line tenderness, is LCL still in, or MCL still in your differential? Yes. But you need to decide whether it's meniscus or bursa as well. Make sense? Your differential is a little bit bigger. Okay, so again, when you're reading these questions, we're trying to give you an insight into that. Decreased motion in the first 6 to 8 hours. Okay, they don't want to move it once the swelling sets in, but they can. Okay, and they can have localized ecchymosis and a small effusion later. Okay, let's talk about this. If the patient has a plant pivot pot non-contact injury, right, they're usually get pretty small. They just do. Okay. When it comes to isolated MCL, LCL injuries, especially if they're low grade, right? Right. You guys know what I mean by low grade, right? Grading it, right? Types, things like that. Depending on what terminology you use. They generally have small swelling, small amount of swelling. Is swelling the same thing as effusion? No, right? Effusion is the joint, correct? So you need to discern whether it's superficial swelling, because if it's prepatellar, that's what it's going to be, correct? Does that make sense? Okay, so yeah, you got to characterize these things. But if you see a large hemocrosis, that lives generally with ACL and PCL injuries, okay? So if you see a large hemorrhagosis, think ACL, PCL, okay? Mechanical symptoms. Again, this is another thing you're going to try to pick out of the scenarios, okay? If the patient presents with snap, crackle, pop, and or mechanical block to motion, you guys know what the mechanical block to motion is, right? We discussed that. Okay, it's actual block, but something's in the way. Okay, it's either bone or tissue. Then you need to start thinking more meniscal. Okay, we'll talk about that, okay? All right, so always examine the uninjured knee and compare. We know this from our varus and valgus stress testing at what degrees and what degrees? 0 and 30 degrees, correct? Okay, makes sense? Okay. And we'll talk about why that's important, right? Right? Do you guys know? Well, we'll talk about that, okay? So when we're talking about tenderness to palpation, they're going to be tender at the specific ligament that's injured. Well, that makes sense, correct? So if it's needle-sided knee pain, then you're going to be palpating the ACL. Okay. Laxity grading, 1, less than 5 millimeters, okay? 2, 5 to 10 millimeters, and 3, greater than 10 millimeters. Okay, so that's your laxity grading. Does that make sense? We do remember that rupture means complete tear, right? Those are the same thing. So don't get that confused. Okay, there's different ways to write that question. Anytime you have an LCL injury, you need to evaluate for peroneal nerve injury. You just have to, okay? So what are the things that the deep peroneal nerve innervate versus the superficial peroneal nerve? Well, they're written for you there, okay? So you need to know those differences. Good to go? You gotta, I would star that, circle it, right? Okay, because you need to know that difference there. Okay, that'll serve you well to get that in your mind too now, because you absolutely have to know that in block 4. Okay, everybody sees this picture here. You understand valgus and varus stress, okay, and varus and valgus deformity if it's present. Then we're talking about malalignment, right? Okay. Again, that's what we're looking for in radiographs. So this is different than a Sagan fracture. Okay. If you have an avulsion fracture at the femoral origin, right, on the medial side, right, the medial femoral conduct, okay, then you're concerned about an MCL injury. So why is it important to know that? Okay? When we talk about here in a second about our surgical referrals, right, you're concerned with the patient based on their exam and the radiographs, you have to know when something needs to be referred. Does that make sense? Can you just treat this with some kind of off-the-shelf knee sleeve, right? Versus a brace, or does this person 100% need surgery? Okay, so we're going to get the MRI. I didn't put that in bold gold because I thought by now you got to know that, right? This is soft tissue, it's ligamentous, and MRI is a confirmatory test. Okay, so evaluate for other injuries. Even though you have an LCL injury, you're looking for other injuries. Make sense? Okay, high-grade LCL injuries always live with something else. PLC injuries, for example. Yes, sir. That there? Depends on the injury pattern. So his question was, how common is it to see this pattern here? I don't know that I would say commonality. I don't know if I think of it in those terms. You just have to remember that if you see that, you're concerned, right? Because is that MCL, that's where the MCL inserts, right? All right? Okay, so is it still inserted? No, it's detached. That's an avulsion fracture, right? Does that make sense? So does that need surgery? Or will that heal? So that's the question, right? So they just need a surgical evaluation, right? All right. So then here, you see how this tendon looks kind of stringy, right? Kind of wavy looking. Okay, that's the MCL as well. Okay, but that's an MRI. So it should be nice and taut, like a guitar string, right? That looks kind of like loose and wavy. Can you guys convince yourselves of that? Okay, right there. I mean, there's a freaking arrow there. But, so it's kind of like wingy and stringy, right? So sometimes that's called a string sign, okay? I don't know if I will use that term, but yeah. But that's an indication that where that white arrow is, that's where it's supposed to insert, right? Doesn't start, it inserts there. So again, you need to be able to characterize these injury patterns. Make sense? Or at least understand what the report is saying. Good to go? So why am I telling you this, right? Because if you get diagnostics, right, and you see this, right, I told you already, that's lateral, right? So that's LCL. And that's also an avulsion fracture, but that's of the fibular head, the proximal fibular head, okay? So you would agree that that's where the LCL is supposed to insert, correct? Okay, so don't get that confused with the last slide. So then you're concerned about LCL injuries, okay? So intrasubstance tear, you guys see the stringiness there as well? Looks kind of wavy, doesn't look like a tight guitar string. Okay, convince yourselves of that, or just read the caption. It is torn. Okay, so intrasubstance, that means in the substance of it, so in the body of it. So it's not an origin, it's not an insertion, it's just right in the middle of the ligament per se, right? It doesn't have to be like perfectly in the middle, but it's just intrasubstance. That's what an intrasubstance is. So we're going beyond what we talked about before, we're just grading it and trying to discern what type of ligamentous injury, specifically collateral ligament injury we have. Make sense? Okay. That clock is throwing me off. One says 10:15, the other one says 11:17. All right, so ligament tears, this is confusing. I get it. I try to highlight the ones that I think you need to know. I'm not going to read all this to you, okay? But I'm just telling you, when you're studying, I would focus on the bone colds and just in general focus on what's bad, right? So grade 3 MCL, well, that makes sense. It's completely disrupted, correct? All right. So but it doesn't involve tibial avulsion. So it's still attached on either end, right? So in this case, the tibia, and it's still attached proximally as well. So it could have a chance to heal. Do you guys understand that logic there? It's still a grade 3, but it has a chance to heal because it's not avulsed. Okay. But what absolutely is operative, right? LCL3s, okay, because whenever you have an LCL3, I'll make it simple for you. There's something else injured too. I keep saying that, right? PLC injuries. Okay. So if you're going to refer this, are you going to refer it sooner or later? Sooner, right? So it's easier to get to things and find out where the ends are, if you will, and tack it down before it starts healing in, right? It's just like bleeding. All bleeding ends eventually, right? It's just whether the patient's alive or not, right? Well, in this case, all things were scarred in will heal, right? But once you get to a point where it heals, it's going to be a more difficult surgery to provide that, to go in there and fix that and provide that stability. Again, I'm not going to read all this to you guys, but is there any questions as you're reading through this? Okay. I can cover this more. Yes, sir. So.
Maybe I'm reading it wrong, but is there any difference
You are.
between the grade 3 MCL at the top and the second grade 3 MCL? Because either are involving the tibial.
Grade 1, 2. I'm sorry. Say it again.
The top bold gold and the middle bold gold, are those not the same thing?
No. So what it's basically saying is that, yeah, it is, but it isn't, right? So one is its own separate category. So the important thing to understand is MCL injuries, for the most part, tend to be things you can knot up, okay? But really focusing on it, even if there's other things torn, they either go together or they go separately. But we look at the ligament that's torn individually, and we look at it together. Does that make sense? So if you have an isolated, maybe that's what I should say, an isolated grade 3 MCL, not involving the tibial avulsion, then that's the only injury, right? Then you're thinking of it in those terms. But if you had a grade 1, 2 MCL and an LCL, it's different than a grade 3 MCL. That's what it's saying. Okay, that is what it's saying. So that's good. So I need to add verses, right? Verses. Okay, and that will clarify that sentence. Thank you. Did I answer your question? Yes. Okay. Because again, when we talk about multi-ligament, that's a really good question. When we talk about multi-ligamentous injuries, it's more than one ligament, right? So that makes sense. Okay. So again, you have to assess these things separately and together. Okay. The second one is isolated. So this one right here is isolated, meaning that's the only one. Okay. So if you have just an MCL injury, you think of that separately. Okay. Does that make sense? You guys get it? So it's not good. Yeah. Yeah, that's what it is. Yeah, it's putting them in categories. That's the way your book is. I will tell you this, guys. I'm not going to ask you questions like that, right? What I want to know is, do you know what's operative? Okay? That's it. Okay? All right? You know, because that's all I want to see. I don't want to see all your non-op stuff. Okay? Oh, you got a question already? Yeah, all right. The room is spinning, sir.
Why is it less common if there's multiple tendons?
Because it has to do with the healing potential for things, okay? So when it comes to LCL injuries, okay, if they're LCL and associated with low-grade MCLs, those tend to do better than if it's a high-grade MCL and an LCL. You ask the question, you get the answer, but that doesn't probably make sense to you guys, right? You have to see these injury patterns. And more importantly, guys, you have to know what those feel like on exam and what those present with on radiographs and MRIs, okay? This is a very confusing thing. That's why we're spending about twice as long as this slide, right? Because but I'm telling you the answer, right? The answer is I want you to know what's operative, right? And just when you should be concerned with this patient, okay? And I will give it to you. I will tell you this. If it's an avulsion injury, okay, you see a piece of bone pulled off, so either this one or this one, always refer it. Okay? Get a good ligamentous exam, because what am I going to ask you when you call me on the phone, Mr. Daniels? What's that? What am I going to ask you on the phone? Because you're going to start reading the radiology report to me, right? I'm going to say, stop. What was the patient's presentation? What was their injury? Right? And what was your exam? Then you can read the report if you want, but by then I stop listening. Okay. Right? Because what I'm more concerned about is what you're concerned about. So I have a patient that presented with this history. On exam, I found this. Radiographs show this. I'm concerned about this. Right? That's where you guys need to get to, is where you're making diagnoses, or at least have a reasonable differential, and you're asking questions. Make sense? Not just send everything to Ortho. If that's the kind of provider you become, you're smiling. All right? If that's the kind of provider you become, I don't know if you're doing your patients justice. Right? Anyway, rant over. All right. Did I answer your question at some point? So you guys know what to study now, right? Okay. Are you recording? Never. Okay. Never. But seriously, I'm not giving you the question. I'm just telling you, if I were to spend time, well, what's high yield time? High yield time is understanding that if it's multiligamentous, it involves avulsion injuries and it involves multiple ligament injuries, again, right, meaning grades of different types of injuries, you need to get that evaluated. Because maybe they need surgery. Do you think we're waiting for the right patient to do surgery? That's the whole reason we do clinic in orthopedics. We don't like clinic, but how else are we going to get patients into the OR? Right? We got to see them in clinic. Does that make sense? So we have a kill ratio, if you will. Okay? How many patients do I need to see to let that dog hunt, right, to get into the operating room? Yeah? If it's greater than 30, I don't like that command. Right? I want high yield patient volumes. Right? So that's the way you should be as providers. You're sending me stuff that you've assessed and say, this patient needs a surgical evaluation. Okay? Better answer? Okay. All right. IT band syndrome. So we kind of danced around this already, right? We can't talk about IT band stuff without talking about the IT band. So we kind of already talked about this in relation to what? Greater-trochanteric bursitis, greater-trochanteric pain syndrome, GTPS. But now this is, and then what, snapping hip syndrome too, right? But now this is just this is isolated, if you will, iliotibial band syndrome, okay? The IT band is the primary area of concern, okay? So it originates again at the ASIS and inserts at Gertie's tubercle. Good to go? We all know that. You'll never get that wrong, okay? So relation to lateral femoral condyle, okay, when the knee is extended, the tendon is anterior to the condyle. When the knee is flexed beyond 30 degrees, it's posterior to the condyle. Okay? Does that concept make sense to you guys? Okay, so when you do a range of motion check and you're unable to get the patient past 30 degrees, or 30 degrees or past, right? You can't get a full assessment of the IT band. Make sense? Oh, incidentally, if you're trying to assess the IT band and you can't flex the knee, are you also concerned about a meniscal injury? Yes. I remember that mechanical block to motion I talked to you guys about? Okay. But anyways, the thing that is important to understand is, you see how it says here, that's the site of pain? I told you already. Is that the only place they're going to have pain with IT band syndrome? Nope. They can come and go. They can go all up and down. anywhere along that distribution, okay? Maybe sometimes they do have hip pain, right? But you see what I'm getting at. Remember I told you knee pain is hip pain is knee pain, back pain is hip pain, back pain is knee pain, right? You need to do a full assessment, okay? Population that gets this, long distance runners and cyclists. Okay, I spent a lot of time evaluating cyclists as part of, as an exercise physiologist, and they all have some degree of this over time. Okay, it gets better, it gets worse. Okay. So pain at the anterior lateral aspect of the knee, okay, that makes sense, right? Worse for running, especially downhill. Why is downhill running more, not more worse? Why is it worse for patients who run downhill? Potentially greater flexion. I'll go with that. Okay. I don't want to get too much into biomechanics. But you would agree that it takes, when you're running downhill, you also have to decelerate, right? Not just accelerate. You can't just go willy-nilly, right? You look like some of those TikTok memes or whatever, those videos that my kids watch, right? People just running off cliffs and stuff. So you got to slow down, right? So you got to slow down, speed up, slow down, speed up. So there's also deceleration and stabilization. So if they have IT band syndrome, it can cause them to have more pain. Does that make sense? All right, so here we go with the Olber's test again. So a positive test is tightness, but what degree of tightness compared to the midline, correct? All right, so at the knee, we'll talk about that a little bit more. But again, it's tightness, but how tight are they? Make sense? If they're super tight, you gotta get them into aggressive physical therapy. If they're a little tight, right, could you give them a handout from that book that I told you guys about? Sure, right? So you have to assess that and say, oh, you're way tight, you need physical therapy. Does that make sense? So your over test is not just a positive finding, it also drives your decision making, right? So if you don't do anything about it, decrease activity level, sure. Lower fitness level, if you don't run, right, you become like me, only when chased, right? So if I had to run right now for distance and time, it wouldn't be pretty, right? So maybe I'm in the 3 mile a year club, right, or something like that. Right? So it is what it is, ladies and gentlemen. It'll happen to you someday. So, but I used to run long distances. If I were to go out there and run now, right, do you think, I mean, everything hurts anyways, but do you think it would hurt? Yeah, it would hurt. So that's part of your history, fitting that, right? So I know there's reservists in here, right? Somebody comes on the reserve weekend, right, because that's when people get care. And they say, I ran my PT test this morning, and now my knee is killing, right? You ask that patient, as astute clinicians, what did you do to prepare for this run? Oh, nothing. I just showed up and ran. I ran like I was being chased. And I made my time, right? So there's pre-existing conditions, right? The reason I tell you that because physical therapy, plus or minus corticosteroids, tends to be IT band treatment. What are you going to do for it surgically? Right? So you really got to live in this area, guys. As PCM, this is where you live. That area of deciding what you need to send the patient to get, right? Makes sense? So would it be reasonable if you're concerned about IT band syndrome that you tell in your referral, you tell the physical therapist to do IT band stretching? That sounds reasonable to me. Makes sense? Make your referrals mean something. Don't just send every knee pain to physical therapy. Physical therapists don't like that. Tell me something, doc. Tell me something. Right? What are the operative options? Not much. IT band lengthening. What does that mean? Does that sound like we go in there and slice it at some point? Let it stretch out a little bit? Yes. Does that put them at risk for subsequent injury, like as in ruptures and high-grade tears? Yes. So we don't do that willy-nilly. Make sense? So before we even consider that, then we would do an injection. But I told you already, when you're injecting those steroids into a tendon or the tensor fasciae lata, right, it increases your risk of rupture. Okay? And there you go. Subcutaneous skin atrophy after injections. All right, if you're injecting right there at that lateral tibial plateau, not the lateral tibial plateau, correct? No, it's either proximal or it's distal to that, correct? Somebody correct me. Maybe I said too fast. All right, so if you're injecting in the wrong place, though, and you inject that fat pad that we keep talking about, or you inject an area that's real superficial, will it cause the skin to kind of dimple and atrophy? Yes. So that we see that very commonly in these injections when they're done wrong, or sometimes even when they're done right. It's really superficial. Okay. Just be careful with that. Okay. So these are the reasons you're going to refer. Oh, this makes sense, right? You have IT band syndrome, but you also have ligamentous instability. Yeah, that makes sense to me. Good to go? Okay. Any questions about that? I want to cover this topic and then we'll move on for the day. Okay? Gastrocnemius tear. Okay, the gastrocnemius tear, in terms of what we lecture on and the topics that we cover in my course, you can liken it sort of to biceps tendon ruptures. Okay, but understand that the anatomy is different, right? But what's intact will stay intact, and what's not intact will therefore not have those forces that take it to wherever it's supposed to go. What do I mean by that? So, gastrocnemius tears, okay, aka tennis leg. I don't know that I've ever used that term, but that tells you the population that it can be common in. Okay, so gastrocnemius tears, is this a rupture or a tear? This is just a tear, okay? Again, don't get that confused with ruptures, okay? Because again, rupture denotes that something's not attached anymore. When you're talking about tears, it's tears, okay? It can be at the musculotendinous junction, which is right here. You see where brown becomes white there? Okay? That's a musculotendinous junction, okay? Or it can be intrasubstance tears. We already talked about that term. You see where that arrow is there? The arrow is there, okay, and it's red. That means it's angry, right? Is that on the medial side or the lateral side? Medial. And that's the most common. You need to know that, right? Because if a patient comes in and starts complaining of proximal medial-sided calf pain, for example, right? Or just leg pain, it may not say calf, right? And they have tenderness at the musculotendinous junction. Is that the most common site? Yes. Of which head, though? The medial head. Make sense? That's how you should think of these things, okay? And most commonly, greater than 30 years old. I already told you this principle, right? I'm not trying to offend anybody, right? I don't really care. But I'm just saying, when it comes to 30, right, I told you, what age do you start getting tight and things start breaking down a little bit more? 35, okay? It's just the law of nature. Things are going to start getting tighter. Things are going to start becoming less elastic. And so you need to put more work into your body, if you will. Does that make sense? So flexibility becomes paramount after the age of 30, 35, somewhere in there. Okay? Incidentally, I looked this up the other day. So middle age, remember I told you how that's a moving target, the definition of middle age? And I'm still correct, right? I think it's just because people are living longer and they haven't redefined it. But Britannica UK says 45 to 65 is middle age. Okay? That's a huge range, right? So what do you do with that range? Right? So go with it what you will. But I'm just telling you, for me, the definition of middle age, right? Yeah, I'm a little bit hurt when people say I'm old. You know, I'm almost ready for the Denny's senior citizen. So, right? But that's at 55. That comes fast, right? So I'm like, am I old? I don't feel myself to be that old. So, but Britannica says I'm middle aged. So I go with that. All right, anyways. So on physical exam, 2 black arrows and some ankylosis in between it. Is that on the medial aspect? Okay. Looks medial to me. Okay. So that's the right side, correct? When you're flipping patients, right? When you're flipping the bacon, you hear me say that. Make sure you know which side you're on. Okay. Don't be examining the wrong side. And you're like, but doc, it's my other leg. All right? That's embarrassing. All right. If you need to, put your hand on their ankle as they flip, as you're flipping the bacon. Okay. But this is the right leg, correct? Okay. Don't flip the bacon and forget which side is the entrance side. Okay. So is this ecchymosis always present? For the most part, yes, but it may not be as present if the injury is more recent. Does that make sense? Okay. So ecchymosis along the posteromedial calf. Okay. There's another way of saying it. Posteromedial calf. Okay. There you go. That just got some ashy feet, right? Dry. So physical exam-wise, when you're doing your observation, right? You're looking at the patient, you're trying to assess, you're looking for tone and muscle pull, correct? Okay? So tenderness and myogastrocnemius, just distal to muscle pull. So you got to find that muscle pull and you got to discern, okay? Right? Ankle held in plantar flex position, okay? So think about this. Does dorsiflexion put the medial calf on stretch? Yes. So the patient doesn't like that, right? So they'll actually sit there on the exam table or off the edge if they're seated, right? Or if they're laying, they'll have the leg off the edge. And they'll be naturally in kind of a plantar flex position. That's a protective position. Makes sense? So therefore, if you say that, if you take the ankle, right, and you dorsiflex it, does that cause pain? Yes. So don't do it to torture your patients, right? But I'm just saying, if there's a question about where the pain is, then you say, okay, it is posterior medial, right? On exam, you want to know, can they do a single calf leg raise? I don't remember which athlete this is, right? But this is a gentleman who had a chronic gastroc tear. Can you see the difference in the muscle bulk there between the right side or the affected side and the left side on the unaffected side? It looks like decreased muscle bulk to me, right? So if you see that, that's evidence that they have a long-standing tear. Do you treat those differently? As the gastroc nevus healed and scarred down, how much can you get from that, right? They may be tired. Maybe they do need a surgical option, okay? That's all I'm saying. Your exam shouldn't just be like, oh, the patient has 2 eyes, brown hair, 2 ears, and they said their knee hurts, right? You're looking for things like muscle bulk and tone. Okay, there you go. All right, so there's the MRI, okay? What's the G and what's the S? Okay. And the soleus, correct? Okay, good. You guys know that. Okay. So soleus tears are gonna confuse you. You don't get into them too much. Gastrocnemius tears, you're gonna be able to discern. Would you say that that is a high-grade medial gastroc tear? Of course you would. It's labeled. Okay. So since it's a high-grade gastrocnemial tear, then maybe on exam they had decreased ability to what? Do a single. I like this. I like the ways you guys are thinking, right? So then it drove you to get an MRI to confirm the diagnosis or ascertain the extent of the injury. Does that make sense? Okay. So then questionable surgery. Okay. Again, do you want to do it sooner or later? Sooner. Okay. Soft tissue causes shortening of the scar tissue, and then causes shortening of the tendon. Well, that makes sense. All right. Once the tendon is shortened and scarred in and healed in, you're not going to be able to stretch through that. Does that make sense? You can send that patient to physical therapy until the cows come home, right? Or the burgers, right? So that's the definition of insanity, correct? If you know somebody has long-standing, they have that deformity, and they have that atrophy, send it, all right? Get an MRI in the meantime, if you can. So DVTs, you guys are probably tired of hearing about DVTs, correct? Don't get those questions wrong, please, right? But is this calf pain? Yes. Is a Hohen-sided calf pain? Okay. There's a student in the senior classes, his name is Holman. I said, if you get this question wrong, I will find you, right? You need to know this, right? Forever, right? Whatever it is. So anyways, non-operative. All right, let's talk about this. Well, we already kind of talked about cam boots, right? Sort of, kind of, maybe, right? The cam boot is that big black boot that you see people rolling through the PX in, right? So, cam boot. Is that cam boot? What does cam stand for? Controlled ankle motion. There you go. Right? I was going to give you guys homework. You love it. Right? Controlled ankle motion. So therefore, it controls the ankle. Does it allow the ankle to move at all? There. So that is, what's the enemy of orthopedics? Stiffness. So do you put just regular Joe Schmo, low-grade medial gastroc tears into a cam boot? Only if you want to have ankle issues, right? But I told you already, motion is lotion, right? And even if you do put them in a cam boot, right? How are you going to take? Because it's going to, when you put them in a cam boot, their ankle's going to be at 90 degrees, correct? So they're going to be at neutral, 0, right? Neutral, right? So not 0, excuse me, 90 degrees. So they're going to be in neutral position. So should you, even if you put them in a cam boot, excuse me, should you tell them to come out of there and do ankle pumps and do their ABCs? You guys know what ABCs are? So they literally take their toe and they write the ABCs. Just that simple. A, B, C. Okay, I'm not going to go to C. Okay? But that's what they do, right? And that's to get that ankle motion, correct? So even if you're concerned about it, they can still do something. Does that make sense? Obviously, if they're high-grade injuries, then yeah, the cam boot is to protect them. But more so in that case, are you going to put them on crutches and make it not weight-bearing probably? Yes, because they're not going to be able to walk. Is it important to be able to dorsiflex and plantar flex to be able to walk? The patient can't do it. Does that make sense? So you need to ascertain whether or not they got it, okay? Compression sleeve, you guys have seen those, right? Brett Favre endorses some, Aaron Rodgers, I'm sure, endorses some, we'll get off the Packers, right? So other athletes, right, they endorse some, right? So again, those compression can help, especially if they have that swelling, and it can help dissipate some of that ecchymosis, right? Is an elastic bandage a poor man's compression sleeve? Yes. Okay, but with non-operative, meaning low-grade injuries, right? Most patients return to previous functional level in 6 to 8 weeks. We talked about this interval. 6 weeks is the shortest period of time you're going to send a patient to physical therapy, correct? 6 plus 6 equals 12. 12 becomes 3 months, et cetera, et cetera. But operative, okay, if they have a large tear, there's that term again, palpable defect. So now, large tear, does that mean like a high-grade tear as well? Yes, it's a significant tear. And they have functional limitations, and you can feel a palpable gap, right? A palpable defect. You guys understand what it means for a palpable defect, right? You feel that muscle belly, and there's an area where you can feel it, and then you don't feel it, and then you feel it again. That gap there is a palpable defect. Okay, so that's what you're looking for when you're doing your twinkle fingers. Okay, makes sense? Oh, I'm sorry. So signs of superficial posterior compartment syndrome should be referred urgently. All right, this is the first mention of posterior compartment, right? But I'm just telling you, if you're concerned about compartment syndrome, is that an acute surgical indication? 100%, right? All right, so if you guys know all those motions that you're supposed to know, right, and what is the extensors and what's the flexors, then the posterior compartment is the flexors, correct? So if you stretch the flexors, then they have pain. Does that make sense? And where do they have pain? Posterior. Okay, so that's interdifferential from calf pain as well. Makes sense? I will not ask you questions on compartment syndrome. Okay, I promise you I would not ask you anything but anterior, because what's the most common? Okay. All right. NSAID risk, yeah, sure. Loss of dorsiflexion, atrophy of the calf, and range of motion, string exercises are not encouraged. Again, the enemy is the enemy, right? It is an enemy for a reason. It's been well identified, and we need to make sure we fight that. Okay. So, large palpable defect, persistent symptoms despite appropriate therapy. So I told you that most tears are medial calf. Most common are low grade, right? Most of them just need physical therapy, activity modification, etc. But they go on to have chronicity, right? Despite appropriate therapy, they still have issues. Then you're referred. Okay, good to go. You think at that point you want to consider an MRI? I would. Okay. And then anytime you have conservative compartment syndrome, it's in red, right? So that's what it is. Okay, so in conclusion, we discussed ACL injuries, bursitis, claudication, collateral ligament injuries, iliotibial band syndrome, and gastroc tears. Okay, I will give you guys a little bit more review tomorrow when the room isn't spinning. Okay, and we'll talk a little bit more and clarify some stuff. Okay, do you guys have any questions now, though? Okay, when is your lab with me?
Next Wednesday.